Ultrasound. There are some advantages for ultrasound and Doppler. This is the first-line modality. It's non-invasive, a low-cost availability. It's no-iodinated contrast media. It can be performed in a real-time and bedside scenario. Some limitations or disadvantages. Most of them are related to technique. There is no capsule of the pancreas, and it can cause poor individualization. It's placed intraperitoneal, and sobreposition of intestinal gas can cause poor individualization too. On ultrasound, the echo pattern is similar to different complications such as acute rejection and acute pancreatitis. On ultrasound Doppler, the resistive and pulsatility indexes are inspecific in some situations, and we need a clinical and laboratorial correlation. Here we can see the iliac vein and the iliac artery and here the pancreas graft. We can identify with color Doppler the Y graft of the pancreas, the venous conduct going to iliac vein, and with pulsed Doppler we can identify the arterial conduct and the resistive indexes, pulsatility indexes, the velocities in the main branch of Y graft. Here on the left we can see a normal pancreas graft with hypoechoic characteristic, and here the ateromatosis of iliac artery. On color Doppler we can identify the perfusion of the pancreas in some areas and the loss of perfusion in the tail. The intrapancreatic branches can be identified using a pulsed Doppler, and we can see the velocities, the pulsatility indexes, and the resistive indexes. Contrast-enhanced ultrasound. It's an intravascular contrast media. It permits perfusional assessment, microcirculation evaluation in a real-time study. It's safe, capable of detecting low flow in small branches without the artifacts from Doppler ultrasound. Contrast-enhanced ultrasound has been working in kidney transplantation, in liver transplantation, but there are no studies for perfusional assessment of the pancreas graft. For evaluation of primitive pancreas pathology, contrast-enhanced ultrasound has been used in different situations, such as for acute pancreatitis, comparing with the criteria of Balthazar, in the diagnosis of pancreatic tumors, and in the evaluation of pathology of the pancreas. Our main objectives with these studies were to establish patterns of graft vascularization in normal grafts and in those with suspected abnormalities, the role of contrast-enhanced ultrasound in the evaluation of pancreatic transplantation, and to compare need for exogenous insulins, the gold standard of reference, and to compare the findings of grayscale and contrast-enhanced ultrasound. Material and methods. From November of 2004 to September of 2006, we performed 30 examinations in 26 individuals. One study was excluded due to technical limitations. We performed the exams in an AGI 5000 using pulse inversion harmonic imaging and a broadband transducer 2 to 4 MHz. On a grayscale, we characterized the echogenicity, the contours and size of the pancreas. With pulse inversion, the mechanical index was placed between 0.25 to 0.5 in the first studies. Now we have been working with 0.2 of mechanical index. The focus was placed at the level of the pancreas, and in the first studies we used a perfluorocarbon-based non-labeled contrast-enhanced ultrasound. We injected 3 ml intravenous in bolus manually, followed by 10 ml of saline solution. Now we have been working with 0.8 of contrast-enhanced ultrasound called Definity. Here we can see the importance of pulse inversion. In a normal grayscale evaluation of the pancreas graft, the pancreas is here. We will see the microbubbles arriving in a grayscale evaluation. These are the microbubbles on the pancreas, and the importance of pulse inversion sequence that we can identify the microbubbles and the perfusion of the pancreas. Contrast-enhanced ultrasound evaluation. We studied some parameters such as elapsed time until pancreatic enhancement occurs after beginning of the injection, enhancement pattern of pancreatic parenchyma during arterial phase, if homogeneous or heterogeneous enhancement pattern, degree of enhancement of pancreatic parenchyma during arterial phase. The degree of enhancement of pancreatic graft was done using a direct and real-time comparison between pancreatic enhancement and enhancement of common or external iliac arteries, and classified as intense, moderate, minimal, or absent. Laboratory exams. The golden standard of graft loss is the necessity of insulin, the exogenous insulin. And in some cases, laboratory exams such as lipase, amylase, and serocreatinine can be altered without compromise of the graft function. In most patients, were submitted to kidney transplant too. Main results. Enhancement pattern in arterial phase. In 19 of 29 studies, we have found homogeneous enhancement pattern. On the left, we can see a grayscale study of normal pancreas graft, and on the right, the post-contrast imaging of the same study using contrast-enhanced ultrasound. In 9 studies, we have found heterogeneous enhancement pattern. This is a grayscale study of pancreas, an enlarged pancreas graft with pancreatitis on pre-contrast series. And on the right, we can see the post-contrast enhancement pattern, an heterogeneous enhancement pattern of the pancreas graft. In one study, there are no enhancement due to graft thrombosis.